Okay, so what happens next? Well, we want to try to help people. And interestingly, this is a slide that someone developed, but I like this slide because it talks about how people recover. And one necessary aspect is safety. Interestingly, they wrote perceived safety. Why? Because somebody can be safe but don't feel safe. Yeah? Somebody can be not completely safe, but they feel safe enough to be able to function and improve their situation. So people need to feel safe. That's what it means. And people need to be empowered to be able to lead their lives. Yeah. Otherwise, they get stuck into challenging situations, both socially, financially, relationship wise, and all that. But when people are empowered to take steps to start to be able to control what they can from within them, because the hard thing is when we're used to having terrible circumstances, it's easy to be a victim of that forever and never becoming a survivor. So we blame the situation, rightly so, maybe sometimes, and understandably so. But okay, so terrible childhood, terrible, then what? Then what? Sometimes what happens is people punish themselves as a loyalty to their pain to prove that it was terrible. Because if they had a terrible experience and then they're fine, it kind of sometimes seems to justify or excuse whatever happened, right? So because they don't want to excuse that, they want to make sure that it's unjust and it's known to be that, then they kind of need to suffer. And that's sad because then they continue to suffer when they don't necessarily need to. It's interesting that I used to work for a one-stop crisis center for women and children survivors of violence, and we do see people stuck in the pattern. So if people had abusive father, for example, then they're more likely to find an abusive partner later on, and even sometimes terribly suffer from abusive children later on. So sort of like that kind of thing. So being able to find one's self-worth despite having had experiences that make you feel worthless is a challenge. But when we help them do that, then it's amazing. They can be completely amazing and can help lots of other people too. So empowerment is very, very important. And connection, when they can feel connected, in that the first connection would be to feel understood in whatever they felt. And understood doesn't mean that we completely understand, because we can't. Everybody's experience is different. And especially if they're horrible, we can't say, oh, yeah, I know what that feels like. But just to care enough to say, oh my goodness, I can't imagine how that feels like, that also builds the connection. And if that person can build connections beyond the helpers and, to other people, that can be life-giving, and it can help them propel them further. And the three are combined, I suppose, because those connections build a safety. Safety also allows them to trust people to build connections. And when they're empowered, then they can feel able to create their own safety and connect and so on. So the three of them kind of go together. Yeah. So I think that I found that interesting. Okay, next. Okay. All right. So personality disorders, what is this? Before we looked at what used to be called axis one. Axis one means in psychiatry, they used to divide people's conditions into different axes. And the first axis is like if there's a mental disorder like bipolar or schizophrenia and so on. And axis two would be their personality. And so they differentiate between the different disorders like the one before with personality. And so there are different conceptualizations of personality. We have our own, and the different groups have their own, I suppose. There's the big 5 personality traits in psychology, and all that. And in psychiatry, we look at personality disorders specifically. And so when we talk about personality, uh, we can't really medicate personality, you see. But people can have medications that help them, even though what they have is personality disorder. Say, for example, if they behave in ways that are, dangerous to themselves, to others, then we might give them medication that's not necessarily a personality medication, but to help them soothe themselves a little bit more, calm themselves, and that kind of thing. Or it might present as mood problems, they might be depressed or anxious and so on. So those components we can treat sort of. So it's a combination of things, but very, very challenging. Psychiatry classifies different personality disorders, things like we call them anancastic personality disorder, a bit like obsessive compulsive, but it's different to the disorder. So there's obsessive compulsive disorder, there are obsessive compulsive personality disorder. So it's a bit like, it's almost like a trait. Yeah, it's almost like the way the person functions in general. So it can be that, for example, there's a narcissistic personality who doesn't really care about other people, lacks empathy, and sociopath, that kind of thing. But a lot of these conditions, they don't come for help, or they might not come to a PRH workshop. Yeah, but it occasionally happens that somebody comes, maybe forced by someone else, like a partner who threatens to divorce them, or an adult child who says, otherwise I'm not going to speak to you, or whatever. So sometimes that happens. People do come, very, very challenging, because they don't feel like, it's something that needs to be treated necessarily. But there's also one called borderline personality disorder. And this one is very likely to come up in workshops, helping relations, and so on. Why? Because they suffer and they ask for help. They want someone to listen to them, to be with them. But it's also very challenging because they do not necessarily work on themselves, or are capable of working on themselves to the degree that we would expect for others. So it's very sad, actually. When we find people with borderline personality disorder, usually it is because of that challenging childhood related to relationships. So experiences of abandonment, whether real or perceived, it can be perceived. Say, for example, the parent had to work overseas or something, and then the child feels abandoned. Things like that can also happen. But basically, problems in relationships where the relationship was essential for the development of someone's personality can manifest in the form of the personality becoming problematic later on. Yeah. And what happens here? They can feel numb, or they can feel intense pain. So it's almost like, one person said it very well, which is, it's like they have no skin. It's like a burn patient. There are different levels of burn. There's a level where the person then feels numb. They don't feel anything because the nerves are all burnt. And there's a level where they still have some nerves, but all the skin's destroyed and all that. So they're in intense pain. So that's similar. So people with borderline personality have problems with boundaries, problems with relationship. Which one is them and which one is others? It becomes very complicated. And so when they feel numb, or when they feel intense pain, sometimes they harm themselves. And it can be very challenging. They can engage in very challenging behaviors. One of the hard things is they seek relationships, but it's a leaky barrel. It's never going to be enough. And so they seek relationships, and they cling to them, and they're very happy when they're validated. But the moment something isn't of their liking, they can go totally the opposite, and react in ways that are totally different to what is expected. They can perceive injury when there isn't injury and that kind of thing, So even the psychiatrists have a really difficult time with these cases. So and psychiatrists and psychologists are recommended to work in teams to deal with such clients. So if they come your way, well, don't be afraid of them, because they're people, and they're people who suffer. But know that it's not going to be easy, and it usually has to be a multi-pronged approach. So having the more the merrier to help these people, because they need to learn skills, also relational skills, basic things, as well as emotional regulation, lots of different aspects. Okay, next we talked about suicide. I'm going to say a little bit more because I think this is very important. Yeah, don't worry about asking the question if you feel it might be relevant. Yeah, if the person says, oh, I don't know what my purpose in life is, that's a clue. Yeah, things like that. You can say, yeah, some people, when they think like that, they even think of ending their life. Has that ever yeah, have you ever come across that thought? And then they might say it, but we need to also be ready for it. See, the problem is some people don't ask because they're afraid. They're afraid, what do we do when the person actually tells us? Yeah, well, don't be scared. That means they trust you. That's a good thing. Yeah, and just simply be there. We can't be responsible for other people's lives, and this is not easy, because we want to, of course, we want to save people. So if we're in doubt, get help. I have had times when I had to call the police or things like that, even, yeah, or just or sometimes our secrecy is something that we can only keep as long as the person keeps themselves safe. But how do we negotiate that? Well, I'll say, okay, that you're at risk, it's not safe for you. How are you going to keep yourself safe? Then we assess. If they say, oh yeah, I've given all my sharp utensils to my sister, so that I never go to the kitchen anymore, because that's risky. That the person is trying to keep themselves safe. If the person says, I don't know, I don't know, I've got the rope and I'm just gonna use it anytime, then okay, we're talking about a more serious situation. Are there people that you can contact or rely on? See if there are, get them involved, and we ask them to do that first. So we say, can you tell them, can to keep you safe, who can accompany you and so on. If not, hey, the emergency situation, if someone has a heart attack in your session, you would go call the emergency services. It's the same. If you need to do what you need to do. And this has happened. I'm a psychiatrist, and I'm trained in this, and it's still not easy. When I was giving a who am I session, and during the break, someone says, yeah, I've already bought this and this, like, oh my God, I'm in the middle of a session, I don't really have time to cater for this person's particular needs. So what am I going to do? Okay, what are you going to do to keep yourself safe? It's not my responsibility. It's that person's responsibility. And if we don't trust the person, then we find someone to be with that person, or as I said, emergency services when you need to. Okay, so there's a range of suicidal ideation, we call it, thoughts of it. So a lot of people might think it, but not that many people actually do it. But it doesn't mean that it's not important, to pay attention to this. There's a lot of passive. It's like, oh, I wish I was dead kind of thing. They don't actually do anything, but they're already less likely to take good care of themselves. So it's a sort of a passive way. So that we can notice. again, I said, explore safety measures. Yeah. If they can do that, and a lot of them do, find friends and so on who take care of them. So a lot of them it's fine. It's more dangerous with men. So be alert to the possibility that for men, they can actually make it happen far more than women. Maybe because of the means that they use, they are less likely to want to fail. So and they're more courageous and taking risks. So it's a little bit of a important aspect. Yeah. um as I said before, explore reasons to keep on living. Thank you for telling me. So, but you're here now with me, and you're telling me this, and this is a good thing. What keeps you alive? What keeps you, here right now? And they will tell. If there are, they will tell. The fact that they're still there, even if they don't know, I don't know. Oh well, it's amazing that you're here. Thank you for being here. And then try to explore it or so on. Usually they have something to hope for, as simple as, I don't know, the next TV series that they want to watch, whatever. But having something to look forward to is important. And so we can also make a contract that that person promises to keep themselves safe. Yeah. For example, please, you need to go to the hospital. Are you going to do that? Yeah. You're going to do that? Okay. If not, I'm going to have to call the ambulance. Kind of, you can even say that sometimes. Sometimes I make them write it down, and they do. Okay, I will keep myself safe. If I have thoughts, I will do this, and then they sign it and something like that. It's also possible. Yeah. Okay. Okay. Next thing is, okay, so take it seriously, but keep yourself calm. Yeah. And comfortable. So keep yourself calm, because it can be very shocking for ourselves. Oh, it can be shaking. Yeah. So do keep ourselves calm. Get HR afterwards if you need to. Yeah. So as I said, there's more risk when there are lethal means. Yeah. And clear plan or impulsiveness. There's more risk if they've tried it before or they know someone who did. As I said, women make more attempts, but men are more likely to have a completed suicide, we call it. And then assistance, what are emergency services, family, keep themselves safe. Sometimes most of the time, they don't want to tell their family. Yeah. It's quite rare for them to be able to tell their family. That's good if they can. And so it can be like a sort of a real relief when they finally, let the cat out of the bag, saying, and then and get family members on board. I've done that. It's like, I say, okay, we need to tell your family. Who do you want to tell? Who do you feel most comfortable? And then the person says, oh, maybe my sister. Okay, your sister. Okay. How are you going to tell her? Oh, I don't know. Can you call her? Oh, I suppose I can. Call her now. Huh? Now? Yes, now. Okay, I'll be here for you, So that way we make sure. And then, and then we help support them. I've done that before too. So things like that, you see what you're comfortable with. Yeah. Don't force yourself to do something you're not comfortable with. But there's a lot that we can do. Okay. So if there are risks to other people, definitely we have to tell someone. Yeah. So as I said, it's good to know you might save someone's life. Another interesting one. I've given help to someone that later on told me, and it's one thing if they later on they say, I thought this date that was already passed, in February, this I thought that was a good date. A good date for what? Yeah, I thought it would be nice to be for it to be written on my on my tombstone. Isn't that interesting? They told way afterwards. They told. So they never said that. I never asked the question also at that time, but the life-giving support that we can give can stop people from actually doing things that they that other people can regret or they can regret. It's regrettable in general. Okay, there's another thing, as I mentioned before, when with borderline personality disorder, this is common. Some people do things that harm themselves, that look like they are trying to attempt suicide, but it's actually not. We find a lot of people are now cutting. Yeah, there's more and more. It's very, very sad. We find children who are cutting. It's very, very sad. Yeah. So when people are trying to, they're cutting, you think that they want to kill themselves, but a lot of them, they actually don't want to die. Yeah. But they're just in such intense pain that it's a way of expressing that pain, releasing that pain. Yeah. And things like that. So some people sort of almost, um, asphyxiate, we call them. Yeah, sort of like try to stop breathing, but they still want to breathe. So it's just until the very, very sort of close to death, and then not really. So it's very dangerous. A lot of them do pass away. So what's interesting is often we say, don't do that. And parents can be very panicking, and everybody can panic. And then what happens if they panic like that? Are they going to stop doing it? Not really, but they're going to do it in secret. So, okay, we don't want them to do it in secret. Yeah. So we want to be able to explore, what is it that you feel when you do that? I feel very, very anxious. It's like something bursts and I have to kind of release it. See, if they're used to experiencing abuse, they're used to anxiously awaiting pain. And once they're abused, the pain happened, and then there's a period of relief. So in a way, it's sort of like, okay, I'm just gonna hurt myself, then I feel the relief after. So sometimes it's like that, or it's numbness. Rather than feeling nothing, I feel something. So we can help them in many different ways. Creative expression seems to be a way that's very useful, because a lot of them, they sort of paint their death or paint their pain or whatever, that can help a lot. Yeah. And then they can paint beautiful things that they wished and so on. And they can paint blood or whatever. And actually that's one of the things people do, since it paint blood and all sorts of different things. But basically they need to be able to soothe themselves. Now these type of cases is very hard, because the impulse might happen at any time. And I don't know what you do to keep yourself sane and safe in terms of appointments, but I wouldn't recommend becoming an emergency service personnel or like a lifeline where the person can call you in the middle of the night or whatever. Please don't do that. Yeah. So I don't know what is available in your countries. Find out what crisis lines are there, what sort of hospital services, if you need to refer people. Okay, so as I said here, there are ways of making it less dangerous for people. Okay. Just now, the question of dissociation came up. Yeah. Interesting. What is this dissociation? Yeah. So dissociation is when we have our conscious mind, the things that we're aware of, the things we choose on purpose. And then we have everything that we don't realize ourselves. Yeah, it can be unconscious mind or programming, meaning the ways we're used to living our lives, even if we don't realize it. Yeah. And sometimes there can be a break here. There can be a break. So what do I mean by a break? So people behave or realize or think things that they don't usually. Yeah. How is it different to psychosis? It's a little bit different, because it's usually more finite in terms of the time. It's a shorter duration, just a sort of like a temporary thing, and then it goes back. And people are not completely oblivious. When people are psychotic, they don't know they're psychotic, right? Here, they can sort of kind of recognize it even if it happens afterwards. Yeah. So for example, people can behave unusually for a short period of time. People, you've seen people in trance, for example, or feeling possessed. If it goes on longer or regularly, then it can be a psychotic thing. So, they can be sort of, but the difference in most dissociation, people function normally. So it's just that brief period. Yeah. And there's a strong cultural element. You will notice that in countries that are not as psychologically minded, we call it. Yeah, they're more there's in not just countries, I suppose, tribes or groups of people where they don't think things in terms of, oh, I am anxious. Then they're not going to be anxious and saying in that way, but they might display certain things like that actually manifest their anxiety. That's an example. Yeah. So, okay, a little bit more about dissociation. Say, for example, we have had cases where people are really, really scared. And because they're scared, then they see things, and they behave in ways like some people use the word hysterical, but that's actually the word that people no longer use. I give you a case. There's a case where there were a group of altar girls, and then one of them said, "Oh my goodness, what is that? Something, I can feel something heavy here. It's like, oh, there's something, like sitting on me or whatever." And then all of the girls got really scared and they started, screaming, and some of them fainting and all that. Yeah, that's an example. So when I explored what was this? Some of the girls had some real problems with their families and so on. And so when the burden feels like a burden, and you can't say that, oh, I feel it's a burden, how do you express this? How do you get it out? And so, they get it out in ways that they don't consciously decide. They're not saying that, oh, I'm gonna say that this because of this, and I'm gonna get attention for it. No, they don't say that. They don't feel like that as well. They feel like it's really, really something at that time. So that's an example. Yeah. Another example that happened was there's a kind of a type of sorority fraternity type of you got to do things in the middle of the night to prove you're one of the group, one of the gang kind of thing. Yeah, that still happens in a lot of young people. And then they go to like scary places. Okay, you got to be brave and so on. And then they scare themselves out and dissociate. That's happened too. But what I'm saying is just be aware and just be there for them. It doesn't usually last very long, but it can be, there's a lot of anxiety related to that. Okay. So when do we refer for psychiatric or other medical attention? Okay, what do we do? Well, in conditions that impact the brain, well, if it's a physical thing, we need somebody who can look at the physical aspect. Yeah. Substance abuse is one thing. They might come to you not because of the substance abuse, but they might need help for the substance abuse. Yeah. I don't know what alcoholism is like in some of your places, for example. Yeah. It doesn't necessarily have to be narcotics and other more severe substances. Alcohol, I think, is the more common one. Behaviors or intentions that could harm themselves or others, they need help. Bipolar mood disorders, we talked about that. That's something definitely needs to treatment. Even if they don't feel it, as I said before, then how do we say it? Well, we can say that, okay, you might feel well at the moment. You might feel really good. Okay, which is fine. I'm glad you're feeling good. But just so you know, conditions like this can also later on perhaps express itself where you don't feel good. And so if it's possible, don't wait until you feel bad to go find assistance. If you can find assistance from now, then we can prevent you from feeling bad later on. Something like that. But as long as you show you care, you're not saying, I can't help you, go away. Of course, you're not going to do that. But some people perceive that when we say, I'm sorry, PRH, maybe it's not a good idea for you to do PRH, then they feel rejected and then they might do things. So wording it in a way that's sensitive to them will be important. Again, of course, if people cannot tell reality, well, then we need to help them get the help that they need. And if you're not sure, just get second opinion. That's the main thing. Why is it very, very important for them to get help? This picture from research shows the trajectory of someone with a mental disorder. Yeah. Symptoms usually start small, right? They don't just go blur like that, even though it can be acute in some cases. But a lot of them, this is just get worse and worse and worse. And the fact is, even for them to recognize that there's a problem, or for somebody else to recognize that's a problem, that takes time. So at the beginning, people are at risk. And that's the at-risk mental state. We call it prodromal, meaning, those moments before you actually get sick, you already feel like under the weather. Yeah, like one of you said, I hope I'm not getting sick, but I kind of feel under the weather. Okay, and then you drink vitamins, and then you get some rest, and drink warm drinks, and I don't know, soup or whatever, and then hope that it never happens. And sometimes our immune system does help. Well, it's a bit like that too in our mental conditions. Sometimes the immune system can help, or sometimes life-giving relationships can help, and that kind of thing. But for some cases, that's not enough. So here there are more and more symptoms. They get worse, and then there's the condition where this is in a psychosis, yeah, in a cases of psychosis, they transition into psychosis. Isn't that interesting? They transition into psychosis. So before that, they're still somewhere in reality. They're starting to kind of maybe be disorganized, confused, isolated, and that kind of thing. But they're not yet psychotic, fully psychotic. Yeah. Delusional means they believe in things that don't exist, or hallucinating and things like that. Yeah. So at one point they transition, but guess what? Even after the transition, it takes so long until they actually contact anyone. And this is anyone, can be a neighbor, can be a friend, or whatever. And then the first contact to any agency is still a little bit longer later on. And then health service, so agency can be like, I don't know, educational system or job seeking system. So not necessarily the health service. And then the health service, and then here's the mental health service. So health service, meaning it can be the emergency ward, not necessarily mental health. And then mental health is way, way later, and then they get treated way, way later. And we call that duration of untreated psychosis. And you know what? It's a prognostic factor. The shorter the duration, the better the outcomes. And if they get treated really, really quickly, they recover really, really well. In some cases, they don't even need extended medication. And also the complications. What happens if someone's psychotic? It's very hard for them to retain their job or their education or all that. It's very hard for them to retain their relationship. So a lot of complications occur if they don't get help quickly. And when they're treated quickly, they regain their lives quickly. So I'll give you an example of two examples. One example is someone who came to PRH, but there's something about their analyses and the way they speak that kind of doesn't make complete sense. It's hard to put their finger on it, sort of like, what are they trying to say? It's a bit here and there, and I'm not sure. All right. So the person has gone to different health professionals and was considered to be depressed and so on, given antidepressants, didn't help whatsoever. So, in psychiatry, the person was placed on antipsychotics and felt better. Their brain started working properly. And you know what? They kept their job. And it's an important job, These are managers. These are important people, and they are able to retain their job and they're able to function well and so on. Wow, isn't that a happy thing? And then sometimes they say, okay, I don't need this medication anymore. Oops. And then they relapse. And then they, okay, I still need it. I still need it. And then they feel like, oh my goodness, I feel so bad about myself. How come I need medication? And then we need to cheer them up in a way and sort of say, go, go, go. It's okay. Don't worry about the medication. Focus on your life. And what I say is, it's like glasses. You want to be able to read, right? You don't think about, okay, one day I'm gonna not need glasses. You don't think like that. You just read. So for me, that's what I tell them, right? Focus on your life. Don't focus on the glasses. You want to focus on the glasses. You focus on what you want to live your life doing. So that's a good, happy story. There's another story with a happy ending, with a sad in between. I rented out my house when I moved to a different place, and the tenants told me that there's a leaky roof. Okay, there's a leak in the roof. I got a handyman to come to fix the roof. Okay. A week later, the roof was leaking again. That's strange. Now, how could this be possible? It was just fixed. Okay, so the handyman went up there and checked what's going on. There were objects up there. There were bottles and shoes and all sorts of weird stuff on the roof. What is this? So we went to explore. Behind the house, there's someone who has been there for 15 years, not doing anything. And I don't know, the person was seeking help, I suppose. The person was throwing things not because they were consciously seeking help, but that's the way they sought help, I suppose. And then I was like, oh, this person's not treated. Why? Oh, yeah, he got stressed when in university. Oh, yeah, what happened? I don't know. He just got really stressed and then he started behaving in weird ways. We took him to the doctor at that time, but he was like fighting and making a big fuss, so we couldn't deal with it. And then so he's just there, and I said, okay, we need to do something. Well, first of all, we need to close this gap so that he doesn't keep on throwing things, but also we need to treat him. If he gets treated, then don't worry about the damage and everything, we'll take care of that, but he needs to be treated. And so we got him treated with injections. There are people who don't want to take medication, right? So what do? There are injections for once a month, for example. They just come once a month to get an injection and then they live their lives. And now he is living his life. And that he didn't go back to where he was. That's the sad thing. If you wait for it too long, then their brain function is reduced. But he can do a lot of things. He couldn't go to university. If he was treated back then, maybe he could finish his university. But he could do things, and he's no longer a burden to the family. That's a good thing. And now, my goodness, that neighbor, their house, they've renovated it. It's all nice, all good. The whole family is thriving because it was such a burden to take care of him. You see, that the family couldn't do stuff, and now everybody can do stuff, and everybody can contribute, and it's finally a happy ending, even though it took 15 years and someone's life almost lost throughout that. So get help, give people help. It can be a lifesaver. Okay, it's almost 11, so I'm my time. It's almost time, that means. But basically, what we can see is what we're doing here is a little bit of mental health awareness. And when we can recognize that we can give help to people, we can give them early intervention, we can prevent situations, and people can get treated quickly. This is where we are. We kind of, sort of recognize things early and help them get help. There's also psychological first aid. You can read about it and you can watch it. There's videos and so on. Basically, it means just pay attention. We do that all the time. Yeah. We listen. We do that all the time. We comfort people. We link them, connect them, find assistance. We try to protect vulnerable groups and give them hope. That's what we do. We're doing psychological first aid without us realizing we're doing it. Important, very, very important. Take care of yourself. Remember, in an airplane, you put your oxygen mask first, okay? Okay, the other person might be gasping for air, but we can't faint. We need to take care of ourselves. So don't feel guilty if you're doing things because you need to take care of yourself. Remember that. So it's an illness to wellness continuum, yeah, where people, what we want is health promotion so that people get healthier, if not at least prevent diseases, if not at least detect it early and treat it early, if not at least limit their disability, and if not at least rehabilitate them so that they can do more things that are productive and helpful for their lives. And remember, there's a mental health system. Find out what's available. Yeah. Because if you have support, then you don't feel alone. Here, I kind of listed some of the supports there. I know there are general practitioners everywhere, the general doctors. There's the internal medicine specialist for things like diabetes and so on that sometimes manifests in terms of HIV, sometimes manifests in mental conditions and so on. Yeah, so lots of things. Neurologists for stroke patients and also all things like that. Psychiatrists. I'm one of them, of course, aside from being a PRH educator. I hope there are psychiatrists around you can talk to and sort of like work with. I hope so. Clinical psychologist, a psychotherapist, that's a possibility. Angie is also a psychologist aside from being a PRH educator, but I don't know what it's like in different countries. Counselors, we work with them. Social workers, also we work with them. So I kind of have a little bit of a sort of a subgroup, a different type of groups where in the counseling, within counseling, there and social work, there's the actual I suppose licensed counselors and social workers, but there are also people who kind of do the similar things like occupational therapists and cultural, spiritual, pastoral care workers, advocates, caregivers, consumer groups, and so on. So where do we sit in all that? We sit a little bit in the counseling, somewhere here, I suppose. Yeah, maybe we need to put a place for us there. PRH educators. Okay, one day. So what are we doing as PRH educators? Well, we're giving them a life-giving relationship. We have that quality of presence, positive regard, authenticity, respect, safety, acceptance. Everybody needs this. Yeah. And then we give them back their own choices. We believe in self-determination and respect. And sometimes people who are in the mental health system, they don't get that because they get people who say, do this, do that, do that. And it can be disempowering. So they need this too sometimes. Connected to reality and responsible in daily life, something very important for us, yeah, with our deep conscience and so on. And then we have a specific pedagogy and a self-discovery process through inner sensations, which some people can do and some people cannot. Don't force them. If they cannot, they cannot. I have another case where, you know how we sometimes use idioms to illustrate our feelings, right? We say, for example, we feel blue. You know, that's an example. The person become very concrete. This is also an example in some of the schizophrenic or psychotic cases. They can be very concrete. They don't think abstract anymore. So blue as in blue, they're going to paint themselves blue, you know, something like that. So it's very interesting. When they read their analysis, it's like, wait a minute, that's very concrete. Okay, that's a sign. Okay. And then we have an explanatory system. And then we have these groups with personal and relational growth. But that means that they have to be able to function. So these are the characteristics that they need to be able to meet in order to use our means well. If they cannot fathom it in their eye, well, how are we going to explain it to them? And if they cannot function in a group, well, we need them if they were to attend a group. Yeah. So things like this will be something we pay attention to. So interesting. This is the recovery tree. This is not PRH, but it sounds like PRH. Self-determination, purpose, motivation, responsibility, spirituality, sense of self, respect, potential, knowledge, hope, well-being, support, resiliency. I love that. It's all PRH for me. We're in the recovery section. And one of my favorite pictures. Happiness is contagious. Maybe we are here to infect the world with happiness. was very interesting that I am now the vice rector at the university because we did a conference, a webinar on PRH, and the rector came and said, I want you to infect the students, the staff with this, with PRH, because it is a deep, authentic happiness. It's not just happy, happy, joy, joy. Let's watch a movie or eat popcorn. Yeah. And then if we can create these happiness niches of happiness, islets of humanity, that's where we are. Okay, so that's our